So what do we say to people? When we're there with people, what do we do? Well, we always ask about what do people value most. And we got to understand as clinicians and as everyone else is that other, people have priorities just besides just surviving. And the only way that we know what that is that we need to ask what is important to the people. The problem is we don't ask. And oftentimes when we ask, it's usually a little bit too late. And being in the intensive care unit, working in the emergency department that I do day in, day out, this is not the best place to ask and we're ready to intubate someone or ready to extubate someone. So what do we clarify? What do we teach our doctors? What do we help our physicians understand? And as I share this with you as a clinician, maybe you can help us to be better doctors by letting the doctors know that this is really important to me, doctors. And so what to clarify is, what is your understanding of your illness? You get so many physicians who's in and out. You have multiple specialists, from cardiologists to pulmonologists to neurologists to intensivists to hospitalists and whatever else there is, and do the doctors talk to each other? And then patients and family are left sometimes in limbo and getting mixed messages. So it's important that we are very clear about our understanding. And it's important as physicians, as nurses, that we are very clear to our family and asking them what is their understanding of illness. What are their fears? Oftentimes people say, well, I fear dying, I fear death. Well, there's something worse than death and dying. That is suffering while you're dying. But what is worse than suffering when we're dying? It's the realization for the family members or the survivors to say, well, there could be something, I could have done something about that to prevent my loved one from dying a horrendous death. And when I go out and give presentations, there's usually a handful of people who come in afterwards and ask, did I do the right thing when I went through this when caring for my mom? Because these are the people that live with those pain and they're trying to heal through a bad death. And we hear about assisted suicide. Well, the problem is, since we provide such bad care of our loved ones suffering from bad death, the community begins to think that, gee, if that is what death looks like, where are those pills? And what we're trying to do is to change that culture. We're saying it is okay. Let's sit and talk about your fears. Let's talk about your priorities, your goals, and how we can be helpful to you. And we always have this hope that maybe things don't happen, the hope that the death isn't so bad. But I think we need to understand that hope is not a plan when it comes to end-of-life care. When the plan is unclear, the treatment plan of the physicians and our healthcare community and the profession is to treat aggressively, sometimes to the detriment of the person who is dying. Family may be left with uncertainties and stress, trying to recuperate from the emotional distress, the guilt and the depression that comes with it, and even the financial concerns. So again, hope is not a plan. So how do we become courageous enough to have that conversation before it's needed? But what are we seeing when doctors have have these end-of-life discussions with patients and family? I really want to highlight some of the myths and dispel them for you. First of which is, there's no change in people's depression or anxiety when doctors have this discussion with them. People actually feel relieved. And so please help us to help you. If doctors don't want to talk about, ask them, doctor, we want to know the truth. So we can take it. So tell us what it is so that we are aware of your concerns. It decreases the rate of CPR. What is CPR? Cardiopulmonary resuscitation. When do we do CPR? When a person's heart stops and they stop breathing, and that CPR is what we do to a dead person. Okay, so we don't do CPR on dead people. We don't have to. Early hospice enrollment. People often think, well, I don't want to go on hospice. When people go on hospice, they die. Unfortunately, there's a lot of myths when it comes to hospice and palliative care, and I'll talk a little bit about that. If we look at the studies from the National Hospice and Palliative Care Organization, we know that hospice is for people with less than 6 months prognosis. The studies and data have shown that about 65% of people die within 30 days of coming on hospice. So no wonder people don't want hospice, because they think that's brink of death care. Well, we go on hospice, I'm gonna die, therefore I don't want hospice. And we know that too, that when people receive palliative and hospice care, the work that the palliative care and the hospice workers do is they can change the outcome, or they change the prognosis of people. So what are some of the proposed solutions? The solutions of what we've been doing here at the diocese is the Care, Prepare, and Connect. We're talking about the pulse, the importance of having the advanced care directives. And these are the things that Patty Mouton and I are going out to the parishes to give talks to help people understand what advanced directive is about. What about the pulse? There's the myths surrounding it. Why is it so important? We're holding community events or conversation cafes where we show videos such as Being Mortal and what you saw recently today called Endgame, where we can have these conversations and we can talk about it as a community and dispel those myths. Now let's talk about palliative care. All day today we hear about palliative care, hospice, and life. So I'm going to give you a pitch on palliative care. The goal is to reduce the symptoms and the stress, as well as caring for the whole person and the family. This is what whole person is about, and palliative medicine is the art around that. The objectives behind palliative medicine is not to hasten death. And it's not here to prolong the dying process either. Medicine and technology makes it so difficult for us to sometimes to differentiate between, are we prolonging life or are we prolonging the dying process? Because we have a lot of things that we can do to the body. So let's look at what palliative care and hospice is in the care continuum. We used the word care continuum several times today. So when a person is first diagnosed with a serious illness and living through this illness as the disease progresses and toward death, the responsibility of the care of medicine, in the field of medicine, is we should be focused on two things. First of which is, can we modify the disease so that we can slow it down or in the hope of a cure? In the beginning, a lot of energy will be focused around trying to slow down the disease in the hope of a cure. But while that spontaneous is going on, we should also be focusing on symptom control and supportive care. And that portion of symptom control and supportive care, and while it's being delivered along with the treatment to slow down the disease, it's called palliative care. So palliative care is big. It's made for people living with serious illness. And where does hospice come in? Well, hospice is a type of care I went a little too quick. Well, hospice is a continuum of what palliative care is. The focus is, of course, is on people with serious illness, is how to help them live well. But when people choose hospice, they're no longer choosing aggressive treatments to treat their underlying disease. And hospice care doesn't end when a person dies. There's also the bereavement service that usually occur up to 13 months. So when you look at palliative care as this big circle, caring for people with serious illness, and as the disease progresses toward end of life, there's this portion called hospice. So what you see here is hospice is only one component of what palliative care is. Palliative care is about caring for the entire person, so is hospice. In the United States, palliative care is often utilized through the hospice Medicare benefit. And so that's why oftentimes people get confused between palliative and hospice. But hospice is palliative care, but palliative care is not hospice. Just like pho is a type of noodle, but noodle is not pho, okay? For the Italians out there, spaghetti is not a noodle, spaghetti is noodle, but a noodle is not spaghetti.